Welcome to A Shot in the Arm podcast. I'm your host, Ben Plumley. Now, what role does technology, and especially artificial intelligence, play in strengthening access to healthcare in developing countries? Could it be the cavalry riding to the rescue of a global health community traumatized by the sudden termination of over 80% of overseas funding from the world's largest donor, the United States? Or is it an excuse to help further marginalized communities already excluded from health services, for fear of providing even more personal information to their governments, or worse, still big tech? And will the only transformation that will result from this innovation be in the size of the bank accounts of silicon tech bros? Well, my guest today is at the forefront of the new generation of global health leaders, and of course, she comes out of the AIDS movement, but her wisdom goes well beyond one disease. We were on a series of conversations about the future of AI in healthcare recently, and I thought it would be very useful to get her thoughts on the state of global health, especially HIV, and the revolution that technology is trying to impose upon us, this time in the case of AI. So, I'm delighted to welcome Solange Baptiste, the Executive Director of the International Treatment Preparedness Coalition, and she joins us from Johannesburg, South Africa. Hey Solange, how are you?
Hi Ben, good to see you. I'm doing well, thanks. Yeah.
So look, we've been trying to get you on the show for a good few years, and we haven't been able to, largely because of your incredible busy schedule. But do you want to just tell our viewers and listeners a little bit about who you are, your background, and what ITPC is, the International Treatment Preparedness Coalition?
I love how you've taken the time to say what ITPC is, because the name is a hot mess because it's like IT and PC, so maybe that gives us the sort of tech view. But we've actually renamed ourselves since 2024 with our strategy just to be ITPC. So sort of like how Kentucky Fried Chicken is no longer Kentucky Fried Chicken, it's KFC. We are ITPC. And that was because we had our new strategy for 2024 for 3 years. And we really wanted to build on the legacy of the HIV movement, where ITPC was birthed since 2003. And so I serve as the executive director of ITPC. I'm based in Johannesburg, as you say, but I am from Trinidad, the sunny island in the Caribbean. And I have been living in Johannesburg since 2018. So it's been a while since living here. So Mzansi is my home now. So we'll see where I land up after that.
Now, I guess straight up front, we should be honest about our connection, because I also have a relationship with the International Treatment Preparedness Coalition, as it was then, although I do love this ITPC. That's really cool. But I was on the board of ITPC way back, and thoroughly enjoyed that experience and to see how it grew. But tell me, what is it exactly that ITPC does now?
Yeah, so Ben was on the board and also my chair, in case people were wondering. So yes, we had a lovely relationship. We are still working primarily for communities. That's in our DNA, that's in our blood, that has never changed. We've just tried to figure out how to be more relevant. So what we were hearing more and more, not that we need to be new or we need to pivot, and this is pre the new era that we're living in 2025, because this strategy came into play in 2024. So since 2023 and post-COVID, we've been trying to understand how does ITPC stay relevant and really respond to the needs of communities. And so we are working on health and social justice through robust community engagement, but really building on that legacy from the HIV movement. So we're still working in HIV very relevantly to the treatment issue, prevention issues, the commodities issue, the access issues, but really understanding that there's a wider ecosystem in which people live. And we can't just say, take these pills and all will be well, when people know their viral load but die of cancer or something preventable because they don't have access, education, or food, and the wider problems that are taking ripple effect now.
I had always thought of ITPC from the view of improving access to treatment, particularly HIV treatment in developing countries. And I'm intrigued and delighted to hear you present a sort of a more holistic approach to the treatment and care and prevention paradigm. How do you see that relating to, and again, this is pre-2025, but how do you see this connecting to the broader health agenda of folk in developing countries?
Yeah, I mean, I think it's really important in this time for all organizations, probably now most relevant in 2025, but there comes a point in any organization sort of evolution where you need to step back and say, what is it that we do and are we still needed? And we tried as ITPC to think, what is it that we do well? And is that specific to HIV? And the answer was a resounding no. We are very good at making sure we address the needs of people living with HIV and affected by HIV as activists and making sure that the movement continues to grow. But there was so much that HIV has led and is leading for the wider health ecosystem that's where that is. So I think what the underpinning foundation of all that we do is related to hearing the community voice. People who are affected by a particular issue need to be involved in that response. So whether it is HIV or it is a climate event, you need to hear from the people that have been affected if they had any warning signals. What do you think the solutions can be? Can you tell us what the ripple effect is? Like, you can get very granular, very specific information for problem solving and actual solutions from them. So I think that's the underpinning here, still in the health space, but not anchored only in a specific disease, but certainly HIV being that platform to leapfrog and so many lessons for us.
So January the 20th hits 2025.
Our favorite date to reference.
Our favorite date. Year zero, day zero. Nothing will be the same. The extraordinary cuts and the speed of the cuts to PEPFAR, to USAID, have really transformed the landscape. And it's not going to be a question of us somehow finding a way of returning to what happened before. It is going to be a completely different world. How have you responded and reacted to this new reality? And I guess I'm asking that question both from a personal perspective, but also as it relates to what ITPC now does.
Yeah, that's a heavy question, Ben. I think from a personal perspective, I have had to do a lot of introspection. And, you know, my mom passed away last year. I mean, it's a bit personal, but I think it's relevant because you kind of think, okay, I'm going to ease into the year. I'm going to heal. I'm going to grieve. I'm going to do things slowly. And, you know, then I think of the legacy that I build from her. Like, what did she teach me? And it's to really push through in those hard times. So I think this is when folks show their resilience, like when you're able to bounce back and you know what you're truly built, what you're made of, what's in your DNA, what's in there. And so I didn't have the luxury of hiding in a corner. If I don't even know if that's a luxury. But it was it had to be a moment where I had to step out and say, okay, not only is this moment calling for leadership, it's calling for solutions, it's calling for an alternative way of thinking, it is calling for us to rally together and also to respond to what communities are facing in the now, but also looking into the future. So from a personal perspective, that's sort of the orientation going on in my head, in my mind, my heart. And then from an ITPC perspective, we really wanted to make sure we were there for communities, the people that we're supposed to be working with and for and supporting. What is it that you're actually facing? So stockouts, if it's confusion in information, if it's being able to help you direct what's going on, if it's just funding, being able to make that advocacy pitch to a donor about immediate emergency funding. And, you know, one of the things that we have been known for as ITPC is community-led monitoring. And that was one of the things that has been chopped. I think it was probably the last into many of the PEPFAR funding opportunities and, you know, services for key populations. All these things have been cut. And so we really tried to see how we can leverage the funds, the opportunities, and the resources that we had to continue community-led monitoring, but as an early warning system, and also to be able to respond to the need on the ground. So giving information to national governments more so than back to donors, to kind of say really what's happening with communities, why are they confused, the confusion with the circular, the memo, the everything. It's absolute utter confusion. So you have overcrowding in certain clinics, because you have less staff. I think one of the things that really rang true for me was the messaging. So after we spent years telling people, take this medicine, take it every day, be adherent, be a good person taking this medicine, we now say, well, maybe there won't be medicine. So what to do now? And it's really not that people were or still are, it's a trust erosion. It's not trusting the health system. You finally built some trust and now it's betraying you again. So here we are. I think that's predominantly what we've been working on, making sure we listen and figuring out how we can use our platform, our position, our influence, our resources to make sure it goes to communities.
Any concrete examples? I mean, for example, I was talking to some colleagues this morning about Zambia and seeing that one of the primary HIV providers for the country, that's also a major research hub based out of Lusaka, is not able to continue to operationalize its clinic. So people are turning up. There is no staff, so they are not able to get viral loads. They are not able to get their next supply of antiretroviral therapy. I mean, maybe the deaths haven't started yet and the illnesses haven't really started yet, but there's a tsunami hitting us. And I wondered if people in your network are feeding back and offering similar examples or different experiences even.
Yeah. So I know that, in Malawi, for example, our community-led monitoring work had identified that the emergency ARV refills were suspended in Malawi. I think that was more due to misinterpretation of the government guidance despite available stock. And so that's alarming. In South Africa, I know patients had been turned away from private pharmacies and instructed to return to clinics for ARV collection, which really just said that the dispensing and distribution system, which they call, I think it's CCMDD, there's a breakdown. So it's a lot of breakdown in the communication of what's going on. And communities have really been able to step up, right? So they aren't the formal systems anymore. So you now have peer educators sort of running informal support groups and WhatsApp and local radio to share accurate information. So don't go to this clinic because it's overcrowded. You now need to go somewhere else. So they have really stepped out to counter misinformation. So also, what do you do if you can't get your medicine? Should you share your pills? Should you cut it in half? Should you take a treatment holiday? Dispel rumors of what might be going on. And, the usual thing, you have emotional and psychosocial support to help when these systems are just overwhelmed, I guess is the word. So this sort of reassurance in the midst of the chaos, and also the health worker situation, right? I think we have in South Africa about more than 15,000 trained healthcare providers across all of the categories, right, put on furlough. I think that was a few months ago. So that we're talking about clinical staff, technical staff, data staff, whose sudden removal, is now just straining the health services across South Africa. So you now have the treatment interruptions and the dangerously delayed diagnoses, right? So it's complete chaos. And this is not specific to Africa. I mean, I've given you more specific Malawi and South Africa examples, but it's across the globe, across all of our ITPC partners.
One of the things I get worked up about is historically PEPFAR had insisted on its own data reporting mechanisms and technology infrastructure. And I suppose in a sense that made sense then. But of course, now that to a large degree PEPFAR is no longer there, data collection has stopped, data analysis has stopped. And it is impossible for countries then to begin to take over and move to self-sustainability, self-sufficiency, when they don't have the information at their fingertips that they should have had, and that if we were doing this properly with a view to transitioning out of overseas funding over a certain period of time, we would have been able to plan for. But we haven't been able to.
Yes, Ben. There is nothing to say after that. I mean, I think when you step back, this is so much bigger than, a cut or crisis in funding, right? It exposes this fragility of a system where we've relied on one donor or one group of countries or one government to support. And this is the problem with aid, right? I remember Ambassador Brooks always talking about, I've built capacity for 25 years. Where's the capacity now? I mean, she was making a point, but you can see when, Bill Gates just said today or something, I think he's going to close the foundation in 2045. There needs to be an end date. If you are serious about supposedly working yourself out of a job, people like me should not still be employed, because countries will be self-sufficient. There would be no need for any of these things because we are truly trying to build capacity, which is why I want to applaud the local manufacturing purchase by the Global Fund for ARVs, purchase from Kenya, from Mozambique. And that's great, but it's a long time coming, man. Like, this is like,
and it's a small number.
It's
a small number. Why are we only here in 2025? Yeah. You
Agreed.
point to the Bill Gates interview in the New York Times, and I'll include it in the show notes. I think it's really important to read, because there is an example of planning for transition. And it's 25 years. It's not tomorrow.
Exactly.
So thinking about funding, what are the alternatives? Where are the different ways of thinking about resources that you are exploring and thinking about?
Yeah, so, sometimes I get the question, why is ITPC showing up in development financing spaces? But it is impossible to have a conversation about the global aid strategy going forward without thinking about the wider context in which this whole problem is being unveiled, I guess. And that bigger problem is really that we have, a $4.2 trillion a year deficit on the SDGs. There is no money for these goals that we have. So where is the public finance? And we have a system where there's ODA, we have this sort of charity mindset, they're donor countries, they're recipient countries. We replenish the Global Fund, we now replenish the WHO. Here's the begging bowl. Please help us because blah, blah. And then we talk about decolonizing, and then we reshuffle the furniture in the room, but we never change the system. And my earring falls off in the middle, but that's okay.
It happens.
It happens. I mean, but I still have one on this.
Yeah, lovely.
But what are we actually doing? And, I just came from the Financing for Development PrepCom meeting. So there's a Financing for Development meeting happening in Spain in June. There's an outcome document. The outcome document does not even have the mention of health. So my first point is global health. We're talking in HIV, happy to speak there. But global health is off the political agenda. The conversation is about line by line, member states, maybe I won't name the countries, but you can imagine which ones, removing climate, any reference to the SDGs, removing any reference to sustainable development, maybe development, but sustainable. Any reference to sort of global multilateralism, it's nations first, sovereignty, nationalistic views. So, what are we actually doing? So that's why I find myself in that space where, ITPC hosts the Global Public Investment Network. I have been involved with the global public investment as a concept, and GPI. We've tried to make it cutesy, and we said the ABCs. So all benefit, all contribute, all decide. It's just an alternative approach to what financing can be for development. So let's stop using fancy words, for common challenges.
Yeah. So you used the term GPI, what does that relate to? How does doing investment differently look like?
Yes. So it tries to shift this paradigm from donor recipient, where we expect these donor countries to always provide, and then the recipient countries don't put anything in and just wait. And you would hear, I mean, I don't always want to reference a particular presidents, but President Ruto has expressed that countries, even Mia Motley, all of them have that certain train of thought, which is we are not a drain on the system. We can actually contribute things. We have solutions to provide. This is also echoed from what communities say. But these countries and the LDCs, these kinds of terms that they use, lesser developed countries, have things to contribute. So whether they can contribute to the ability to pay, but they put something on the books, that's the point here, right? In GPI, the idea is that everyone can contribute, but everyone has to decide. So let me just talk a little bit, if I could put people's business in the street. The Global Fund, let's just think that's the closest example that we have to GPI in practice. But we have other examples of GPI in practice. So like Indonesia contributing to the pandemic fund, countries that you don't know are traditionally recipient countries now contributing. But what has to happen, there's always willingness from the recipient side to contribute. The poor countries will give some money. That's what I'm saying. The rich countries don't want to give power. So they're like, only 6 of us, we give how many billions? We don't want to give you a seat at the table to now vote on how things are decided. And therein lies the linchpin of the problem. So that's where advocacy comes in.
I think you've absolutely hit the nail on the head. Everything's wrong, from the power dynamics to the language. I mean, you think about the term donor and recipient countries. Well, 100 years ago, it would have been the colonizer and the colonies. And we have had 250 or 300 years of colonizers taking the resources from the colonized countries to enrich themselves. And now we are talking about, you're a recipient, you're a least developed country, it's your fault. Well, no, it isn't. It is history. It is the impact of the way that the old capitalist model worked. And I'm not going to get into the politics pro or anti-capitalism here, but the point is that the conversations need to be about a solidarity between equals. You mentioned Bill Gates today. Another announcement: the UK is going to hold a donor conference for the future of overseas development aid. I can't believe the Foreign Secretary, David Lammy, who I really deeply respect and really should know better, but he shouldn't be thinking in these terms. The conversation should be partnerships with countries in Africa, for example, Africa being the economic and population powerhouse of the 21st century. How do we work together? How do we build models of mutual solidarity? I just beggars belief.
Yeah, but that's never going to happen, Ben. So my new theory on this now, we need a strong, unified African agenda. Not to say that Asia and Latin America, but we need to build something based on the right principles, whatever GPI, all of it is sort of Ubuntu principles. The company is happening in the community. Let's all contribute. Let's all benefit. Let's all decide. And if Africa can have a unified, strong agenda, the power of the AU, Africa's CDC leading lots of different things, if we can get this continent, whereas the youth bulge and all of the natural resources and all of the innovation and technology, local manufacturing, all the potential, that's when the other power holders will see it as a threat. If they don't see it as a threat, they're not going to give away the power. The wishful thinking, I think, is in our hearts, where we want to have multilateralism and we want, why don't you cooperate? You're not going to cooperate because the system is designed, as far as I'm concerned, well. It doesn't work for us, but the system is designed and it works damn well. It works well for those that hold power and want to keep it as is. And so all the incentives are in place for that. So we need to go do our business for ourselves and show that we can also be a force I'm not only talking about contributions as money, I'm talking about community intelligence as well. Communities in a national setting contributing to the, I mean, you started on AI, but what is the intelligence that can also feed? It's not just about the dollar. Solutions come from young people, from people who are living the experience, and we need to tap into that as well.
And the creativity that comes when you've got a certain amount of money, no more, and you have to make difficult choices. But let's get on to artificial intelligence. And, you know, whether you like it or not, Solange, you have become the artificial intelligence queen of the HIV movement, nay, of the global health movement. Do you see artificial intelligence as a net plus or a net negative? Or do you have a completely different take on it?
Yeah, good question. And I think it's come up in every conversation, right? Like whichever donor you're speaking to, whichever community group, there's always this question around, well, and what about AI? And how are you going to leverage AI? Honestly, Ben, my personal view, and then I can tell you what I have heard from communities as well. So there's a Lancet commission that I'm part of that's looking at AI. And there's also the UNAIDS work on the strategy, and we're looking at digital health and AI in Africa for the commission as well. And I think my personal view is that it's a tool, and all tools you just use. The caution and the concern that I have is that the tool has to be put into the hands of communities, not replace communities. Because like Kanye West said, what, better, faster, stronger? I think, yes, you can get better, faster, stronger, because these algorithms and learning can happen so fast and they can process so much more information, but not to replace the lived experience and the community's solutions, right? There are so many studies that show that these things also have built-in bias. So you need to have these guardrails, but there's absolutely no reason why communities should not have AI as a tool in their arsenal, especially when doing things like community-led monitoring, community-led research, being able to analyze the data that they have and come up with solutions. I think it's
So first up,
asset.
I cannot believe I'm chatting with you and you bring up Kanye West. So that's... but
I mean, why not?
But the interesting thing here is that it's a tool. It's a tool to be used by communities. And I do wonder how you define communities. But in the context of improving access to healthcare, for me, artificial intelligence does something really revolutionary. It takes away the need for us to build hospitals. It takes away the need for us to try and duplicate, say, Nye Bevan's National Health Service for Britain in the 1940s. It can bring expertise to village clinics, to community health workers in ways that we never ever thought possible. It gives us the opportunity to diagnose much more rapidly, to explore perhaps complicated conditions, complicated challenges, and it frees us up from the need to refer people to centers of excellence that are physically located, potentially physically constrained, but it allows the expert and the frontline carer and the frontline consumer of healthcare to be more connected. And that's what I find so enthusing about it. But of course, there are a whole lot of other issues that go with that.
Absolutely. It reduces that gap. There's that distance where you had to have so many layers of things, and now one person in a village somewhere with some sort of device can now speak. I've seen the bots and the apps and the different examples of like self-care from anywhere, and you can ask a question, and they're actually quite empathetic. And in some cases, better than the human who is like with stigma and issues and seeing all the problems. They give you the facts, and they're trained to be like thinking, okay, maybe this person's also concerned about gender-based violence, or this person's also concerned about reproductive health services. So they make all those links and the referrals, and it's all embedded really well. But the problem is, can everyone find this access? right? Data. I mean, I'm sitting in South Africa, and to be honest, I still have a phone that is not only not only South African, because data is so expensive here. It is redonkulous. And so, how does the average person access this stuff when there's so many structural barriers outside of health that we need to think about? The cost of data is just prohibitive.
It is. These are some of the things that we don't take account of. The joke is it's a first world problem that we think about if we can't get immediate access to our Instagram or our TikTok. But the other thing that you raised in one of these meetings, and the context was one colleague saying, well, look, the HIV movement has to explain why it is particularly at risk from more digitalization, more electronic medical records. And I thought that was an extraordinary statement to make because of precisely the stigma and discrimination, the persecution that goes with the people who are most affected by HIV, key populations. And by that, of course, we mean men who have sex with men, drug users, sex workers. Very often we also mean girls and women. And I just wonder how you feel that the global health field is thinking about more than just sort of basic protection of people's data, but how the move to digitalization of healthcare can be, how it can be mobilized as a force for good rather than it being exploited by governments who, let's face it, may think for a variety of reasons that these key populations should not be prioritized, should not have access to healthcare.
Yeah, I mean, good question, Ben. I don't recall what I said to that, but I do think at the end of the day, HIV is a moralized disease. And it is one where you still have to make sure you come back and realize that there's so many risks to certain populations in disclosing their orientation, their lifestyle, whatever it may be. It's a risk. It's actually a risk. And I remember I did a presentation, whatever, and the first slide I put up was this sort of medical records, and then I put a bed. And people were like, what is this? And I was like, this is where, if you're living in this country, which I will not name, you have to hide your records under the bed because this is too risky to put somewhere digitally. And there's a risk of when this government comes through that these people will be literally criminalized and harmed. And so it is a huge, an important point that you make. And I think what I would say to your question, Ben, is that there's this concept of understanding the embodiment of your data, that your data is not delinked from you, that your data is actually a part of you. And the example, the way I started to understand was the question that was brought to the room was, would you prefer everyone to see your entire chat history on your internet browser? Or would you prefer that they take your DNA, a blood sample, and tell you what's in your genetic code? And resoundingly, no one said, check my internet. They said, take my blood any day. So they wanted to protect their data, their privacy, their information. And so the fact that we feel that we could extract data and information from communities without understanding that this forms part of a sort of a community web of information, and this always then happens in the poorer countries where, you have these tech giants that are looking for data sets and big data. And so we really need to put guardrails, and particularly understanding that HIV is a unique, specific kind of disease. This is not malaria. There's a very different kind of conversation, even when we talk about CLM. We talk about the kinds of indicators and the need for protections. It's very different when you're talking about mosquitoes, right? It's very different. So I think there is a certain sensitivity to that. And it's important. And I think my last point here is that AI, I do believe, because some people, when you start talking about the AI, they roll their eyes and like, why is this? This is a luxury first world thing. You're bringing this in Africa. What are you talking about? But AI, especially in this context where there's a funding shortage and a crisis, can free up resources if used appropriately. So community appropriateness, ethically, with guardrails, it can then free up the resources, the human resources, the money, the little resources that are in the bank for commodities and anything that isn't really needed by a particular population so that they can get that. So if they do it better, faster, cheaper, then this is what happens.
Do you think that our colleagues in the global health community understand that? Or are they still enchanted by the shiny, silvery new object that AI offers in terms of, let's say, drug development or the ability to produce research papers much more rapidly for publication? I'm not sensing that there is a really informed conversation about the beneficial future of technology, particularly AI. Maybe we're not doing a good enough job of expressing it beyond some of these commissions. Maybe the conversations are happening there. But I don't sense that there is a truly informed enthusiasm or even a conversation happening.
I agree. I do not think that there is a really vigorous, informed, I think communities generally also don't know what's the entry point for this conversation. Like, you're talking about something over there that hasn't really hit my life, unless you're in some sort of trial for an app where you get to talk to a chatbot and you're like, oh, this is cool, but will I ever really have access to it or use it in my daily life? When will it materialize? I don't think that it has really hit home yet, but the potential is there. And I think, if it's part of the global aid strategy, if it is part of this commission, which would then lead to more implementation studies and really embedding it, the point is it has to start from design with communities at the core, not in the evaluation, because we are good for coming up with an app and be like, hey, I made this for you, go use it. Why aren't you using it? Why is it not effective? Let's do an implementation study. Can we start from the beginning with the users in mind? Those are embedded in the HIV sort of learnings all the time. So I think that's the key to untapping this potential.
And the other thing is really to understand the innovation and the transformation that comes from innovation. Again, in some of these conversations, it was, big tech. And it was sort of like the conversations that we used to have about big pharma, and we've just changed tech. We've replaced pharma with tech.
Yes.
Most of these innovations are happening inside healthcare, are happening in small startups and in research initiatives. And we need to be better connected to them.
Absolutely. Sort of same nonsense, but just a different outfit, right? So it's the same problem that you can think of, even with the financial problems that we're talking about. It's the idea of relying on one group. That's called monopoly. And we have this problem in the access space for pharmaceutical industry. You have the same problem with funding. And then, as you said, with sort of big tech. So it's just the same inequity, just manifesting in different spaces, I think.
So we're coming up to the top of the hour, and I realized I haven't asked you to look into your crystal ball and sort of tell us how you think let's start with global health more broadly. What global health looks like in the next 5 years. Do you feel you are able yet to say, coming out of all this chaos and confusion, this is where we've got to start prioritizing? You mentioned the importance of community, but we've always said that. How is this time different, and how do we take the opportunity to get to where we need to be with so many of the sacred cows, if you'll excuse the metaphor, having been slaughtered for us?
That's a tough question. I certainly do not see a future where there is a lot of funding from the US government for this kind of work, or traditional donor countries. if I have an optimistic view, because the crystal ball, depending on how I roll off the bed, will look differently. Um, I would see a really strong African response with governments stepping up and really being able to show the continent's potential, particularly in Africa. I think it's ripe for that, for that kind of leadership. We have a lot of leaders, but we don't really have leadership. And I think it's really time for sort of that distributive leadership. I think we would see leaders from the communities, leaders in the national response, and leaders in the African continent. And I'm not so sure if I'm super hopeful about multilateralism as a whole. Like, I'm not sure what's the future of UN or multilateral funding. You know, I mean, we have a part of the Change community, which is this coalition that kind of emerged out of the emergency. We've been talking to the international financial institutions, the World Bank, Pandemic Fund, and they're all concerned about, you know, it's the same problem. They're on fragile ground. World Bank needs the US to be able to leverage funds. They are a bank, so you want to tread carefully. Like, these are everyone's walking cautiously. So I think the future of multilateralism is really a big question mark, but it is worth the effort. I was asked a question at some other meeting. I think the most important thing for me is that when I am getting older, I need to be able to look my children in the eye and say, I tried. We tried. We didn't just let this stuff go bad and go south and watch it happen. So whatever it is, I really hope that we're all doing our best in our respective corners, and we can look people in the eye genuinely, like the next generation, and say we did our best. We fought for what was right, what was ethical, because at the end of the day, human beings should be able to access healthcare just because they're human.
And if we're going to be successful, if we are going to win, that is going to need us to fight. So whether we fail or succeed, we have to fight. It's a precondition for everything. Yeah, I completely agree. Oh, that sends shivers down my spine, Solange, just hearing you say that. Have we missed anything? Is there anything that you feel our listeners and viewers ought to know? Like, Ben, you didn't ask me this. Why haven't we covered this?
I mean, I think not really, Ben. Maybe we could talk a little bit about the affordability concerns in HIV. It's coming front and center now because we have less money. So every government is, well, the resounding like mantra is national governments need to step up. No one's coming to save you. Okay, where is the money going to come from? And there's only so much you can do to tax people. When you're a poor nation and you're paying in US dollars and your interest rates are crazy and you're drowning in debt, you're not going to get new money. So is it a reallocation? And then it comes down to the question of, well, why am I buying something that's so much more expensive than my neighboring country? Or why is this commodity so damn expensive? And so I think it's really important to demystify the myth that this is an elite space for intellectual property and patents and trade and access to medicines. And we have, as ITPC, our Global IP and Access to Medicine Summit coming up next week, actually, in Morocco. And that is really to kind of hear the community perspective and see the community wins on that. So market oppositions and market reform, law reform, patent oppositions, and really making sure that the access issue is one that is brought front and center, because the cost to manufacture is very different from the price that people pay. I don't think we often think about that.
We don't think about the value chain, and we have the ability to influence value. Two thoughts on this. The first is that in this new environment, I think we have to think of researchers and manufacturers as all part. I mean, we were always part of a big dysfunctional family, but we have to look at partnerships more now.
Yes.
And any commercial organization that says, let's exclude Africa from the conversation, any commercial leader who says that should be fired immediately because they're not thinking about the future of their business. And I think the opportunity for us is really to create the foundations of these markets of the future. And quite frankly, they are going to be driven by biotech innovations from Nairobi, from Lagos, from South Africa, from all over the place. And that's exciting, and we should embrace that. The other thing that I think is, for me, a bit of a cautionary thing is not to, okay, how do we punish the US for what it's done? How do we change what it's doing? How do we get back to what USAID was at the beginning of this year? And I don't think that that is a helpful strategy. I think what ultimately the last few months have demonstrated to us is that global solidarity cannot be built on donor largesse. It has to be, going back to what you said earlier, rooted in a partnership of equals. And there is all sorts of different values that people, countries, communities bring to the table. And that has to be understood and brought to the fore now.
Absolutely. And then they won't pay attention because it doesn't hurt them in their pocket or in their immediate life. That's where all these, like, I often, like, if I am in I don't mean to take the wind out of your sails, man. That was a really important point. But I've made that point before, and so what? It doesn't move. Like, human rights and, COVID came, and what did it reveal? It revealed that even in that time, what we will do is hide our recipes and do backdoor deals and breach contracts. That's what it revealed. So why would we expect now that we would act differently? Sorry, I don't mean to not.
No, yeah, and I tried to do this to Mitchell Warren in a previous episode, and I tried to piss on his parade when he was thinking about the future of lenacapavir. And, I totally get this. But I'm starting from a place, and COVID's a really good example, where countries who were put to the back of the queue, even with COVAX, even with these Geneva-based multilaterals supposedly trying to work towards equity, they realized they were on their own and they had to do things their own way. So the creativity that came from mobilizing community health workers for TB and HIV to be community health workers for COVID. And by the way, those very same workers were people most affected and, frankly, most killed by SARS-CoV-2. There are things there, but it requires us to change fundamentally the way we view the world. And it requires us to accept that this is going to be a fight that is not sorted in 5 years. We're not going to end any epidemic as a public health crisis in 5 years. This is a systemic change, the battle for the hearts and minds of the 21st century.
Yeah. And it's sort of a generational thing. You have to see sort of generations pass because the entire system is not going to there's no incentive for the system to change. And I think your point is ultimately we have common challenges that we cannot fight individually, like as nations or as humans. We have to come together to fight certain things like Marburg, Mpox, things that are crossing borders that don't care about all these things. And until we use the crisis in a way that can actually bring about that systemic change, we're just going to keep repeating because humans forget, right? Back to our old ways. But there is hope, Ben. There is hope. Fix your face, smile.
Well, I'm glad you're saying there is hope because I was one of the reasons I wanted to do this podcast with you is that you are so direct, bullish, but ultimately optimistic, a bit like Bill Gates, about where we can go from here. And I think it's really important that as, older dinosaurs like me hand over the baton, that gives us too much authority in this. But as people like you grab the baton from folks like me who were perhaps a bit more mature, maybe a bit more older,
wise.
I wouldn't necessarily go that far, but certainly we've got to be looking at what we can achieve rather than looking back at what we've lost. And what I find so much I appreciate about you, Solange, is that you frame the challenges in that way. And I really, really value that.
You're most welcome. I'm battling myself, but this is where I think I am. So
yeah,
thanks for acknowledging that.
Well, Solange, thank you very much for being on the podcast. I hope you'll come back and keep us updated. And I promise to do a better job of WhatsApping you and saying, hey, where are you? Can we get together? Really deeply appreciate this conversation. Thank you.
Thank you, Ben. Thank you.
Well, that's it for this episode. Thank you so much to Solange Baptiste from ITPC. Love that. Thanks also to Erica Spera, our director and producer from A Shot in the Arm Media. And finally, a big thanks to you. Of course, you can access this and all of our other podcasts on whatever podcast platform you use. And don't forget to check us out on our YouTube channel. Give us 5 stars and subscribe. With that, have a great week and a safe week, everyone.